Brooklyn Independent Television.
Welcome to Healthbeat Brooklyn on Brooklyn Independent Television. I'm Dr. Monica Sweeney. Perhaps no decision a woman will ever make compares to the choice to become pregnant, to bring another life into the world. It's a long journey, however, between that first step and the desired result, a healthy mother holding a healthy baby in her arms. Think of it as a continuum that spans the lead up to pregnancy, the 3 trimesters spent carrying the child, and the first weeks and months after giving birth. Too many women simply don't know how best to take care of themselves, leading to problems like low birth weight, failure to thrive, even birth defects, and in some cases, the death of the mother or the baby. Joining me to talk about all of this are Dr. Charles Bowers, Chief of Obstetrics and Gynecology at Kings County Hospital Center, Dr. Gloria Valencia, Director of the Neonatal Intensive Care Unit at SUNY Downstate Medical Center, and Lisa Landau, Executive Director of the Nurse Family Partnership at the New York City Department of Health and Mental Hygiene. Thank you all for being here. I want to start with talking about the choice to get pregnant, is what I just said, and then I want to talk about it. How many women plan their pregnancy approximately?
Probably not enough women. Too many women are having spontaneous pregnancies without planning, and I think that's part of the problem that you've addressed.
The thing is that a lot of women, by the time they come in for prenatal care, have not done anything except diagnose the fact or had somebody or do a test. So what's with the planning?
Well, I think that in many cases, by the time you come to see a physician, the die has been already cast about what the potential outcome is going to be for your child. I think preconception counseling and preconception preparation for pregnancy is most important. If in fact you're going to get pregnant, I think you need to be aware of the fact that that's what you want to do, and you need to start modifying your diet, your habits, eliminating those social abuses, drugs and/or alcohol that may contribute negatively to your pregnancy, and also begin to start considering who's going to be your healthcare provider, which I think is also a very, very important decision.
Oh, who's going to be your healthcare provider? You know, I heard someone say not long ago that women spend more time finding out and know more about their beautician and their manicurist than they do their doctor. Do you think that's true?
I don't disagree with that statement. I think that too many of us choose our physicians for superficial reasons. He's cute, she's cute, his office is uptown, he's a man, she's a woman, he's black and he's white. I think when it comes time to choose your healthcare provider, you need to go to that person who, first of all, is intellectually sound and solid, but then secondly of all, has demonstrated compassion and concern for you as an individual. I think that the decisions of taking care of a pregnant woman go beyond the science. They have to include someone who is going to have empathy for you as the epicenter of your family. When in fact you're taking care of women, you're taking care of somebody's mother, wife, and/or sister. And in our communities, the mother is the epicenter of our community. So therefore, you really need to make sure that that person or persons who are going to be taking care of you not only are concerned about your health, as your physical health, but also as equally as concerned about your mental health as well.
The whole person.
Correct.
You know, I didn't ask this question, but I want to go back to it for a minute. We haven't gotten to what happens if you don't do what you've just described, Dr. Bowers, but how bad is the problem of infant mortality in our communities here in Brooklyn, in New York City or in Brooklyn, whichever you can give me?
Infant mortality, the highest as it now stands in 2007, in the 5 boroughs of New York City is the highest in the Bronx, followed by Brooklyn. And
so Brooklyn is number 2 in infant mortality.
Number 2 in infant mortality.
And the number, would you tell our audience what the number is?
It's about 5.4% for Brooklyn and about 6.4 for the Bronx in 2007.
Explain what that means. For every
100 live births at the Bronx in 2007, about 6 to 7 children would die before 1 year of age. And in Brooklyn, about 5.5 would be dead at a year of age for every 100 live births.
So that is a significant number of children that are dying before their first birthday.
Yes.
Now, for maternal deaths, Dr. Bowers, how's it looking now?
I think the number of maternal deaths has really dropped dramatically. I think the advances that we've made in the science of obstetrics has significantly ratcheted down the number of deaths. We are much more concerned about, we are much more knowledgeable about hypertension, obesity, diabetes, and many of the hospitals in the city, especially on Clarkson Avenue, where Dr. Valencia and I work, you know, we have significant programs about patient safety, about eliminating errors, medication errors that may contribute to mothers dying. We are concerned about hand washing. We're concerned about postpartum hemorrhages and the like. So we all have instituted important advances in those areas to try to keep the number of women dying from dying.
Dr. Bowers just went over a list of things that are done when women come in to deliver to decrease the chance of a poor outcome for the mother and, of course, for the baby. But what you see are the poor outcomes in the neonatal ICU, which is called the NICU, in case we just slip and say NICU again. Could you talk about some of what happens when you get the babies in the neonatal ICU? Why are they there?
As you said, the continuum. I deal with consequences of bad pregnancies, and one of them is preterm birth. There are several kinds of prematurity. There are the extreme low birth weight babies, and there are the low birth weight babies and the very low birth weight babies. So
just for a minute, would you tell the audience what a low birth weight, the definition of low birth weight?
The definition of low birth weight baby, according to the World Health Organization, is any baby born less than 2,500 grams.
Which is in pounds?
In pounds is about 5.5.
Any baby born under 5.5 pounds is considered low birth weight.
Low birth weight.
And very low birth weight?
Very low birth weight is less than 1,500 grams. And extremely low birth weight is less than 1,000 grams. And the extremely premature babies are those less than 750 grams. And
do you have babies surviving who are under 750 grams?
Yes, yes. It's an 80% survival, I think, on both sides of the street for those babies.
That's like holding less than about a pound of meat in your hand.
It's about the size of a good reference would be the size of the Muppet Babies. When they had the Muppet Babies, they're about that size.
It's amazing that with the invention of the institution of neonatal ICUs, that babies can survive at that low birth weight.
Yes.
So low birth weight is one thing that happens. Mm-hmm. What are some of the other outcomes other than simply low birth weight? Because if it's just low birth weight, you keep them there and feed them for a while and they'll come out. But what are some of the other outcomes?
No, the extremely low birth weight babies are quite problematic because they stay with us for several months. They have premature lung, and Dr. Bowers knows that we're always there for the cesarean section and the delivery, and we give them medication to mature the lung. This is actually the continuum of their work because every woman on preterm labor is given steroids, and that is a factor that will improve outcome.
Right.
We follow that with surfactant to mature the lung of the baby, and that's just one problem. The other problem of the very premature baby, a third of them could bleed in the brain. And that's not a very good thing to tell the mom because we do see them for consultation prior to their delivery. The other thing is infection, because these babies are so at risk that they are born prior to the ability of the mother to give them some protection for infection.
So we now know that the mothers can do okay pretty much if they get into prenatal care early and all of that. But some of them still have low birth weight babies. What contributes to prematurity? Why are babies born prematurely, Dr. Bowers?
I think there are a lot of reasons and a lot of causes. There are health issues, hypertension, obesity, diabetes. I think there's also a psychosocial impact.
The same big three.
the same big three, but I think that most importantly, as we all know, there's a big disparity in the minority communities about their babies dying compared to those women who are not of non-minority. A college-educated African-American woman who's married, who got a degree from Harvard, her chance of her baby dying is greater than a high school dropout Caucasian. And so therefore there are psychosocial issues that contribute to some of the poor outcomes that we see in our communities. That goes back to our grandparents and the like. I think that the things that we try to do on a daily basis to improve women's health also need to be complemented or supplemented by improvement in social standing, education, and other important.
Even though education can't erase all of it, it can certainly help with some of it.
That's great.
Now, one of the programs that I really admire and like and wanted to ask Lisa about is the Nurse-Family Partnership, which is out of the New York City Department of Health. Would you tell us about that and what you do to try and improve these outcomes?
Sure, and it's a great moment to talk about it, just in terms of what Dr. Bowers just raised and the psychosocial piece of the picture. So Nurse-Family Partnership is a program that links nurses, specially trained nurses, with first-time low-income parents in the areas of highest need in New York City. We're in all 5 boroughs. Those nurses work with clients during pregnancy and through the child's 2nd birthday. So arguably the earliest intervention program, where the nurses are working, in the various realms of the development of that mom and the baby, with lessons every other week in the mom's home and dad's home, to really lead the mom to understand more about her own health and how to take care of herself and how to take care of her baby. And
it's for first-time moms only.
That's correct.
Okay.
The idea is really that this is a program that hopefully will have an imprint on the mom and dad for that the first baby that will be lasting to the next baby and the next baby. And it's really about more than health. It's about planning for your life, planning for your own health, for your baby's health, learning how to parent better, but also in the context of planning your life. So continuing your education and continuing to focus on your goals, small steps at a time, but really
for 2 years.
For 2 years, and engage that family to move themselves forward for their own sake and their child's sake. So it's really, about the next generation and the mom and dad.
You mentioned several times the mom and the dad. Mm-hmm. And I know we don't have a lot of time to spend on this, but in many children born in the Black and African American and Caribbean community, there's not a mom and dad in the home. You'll still go in the home if it's a one-parent family.
Oh, absolutely. I would say that consistent with the statistics on single-parent families, that most of our 2,400 families are in fact single-parent families, and we've now seen.
Does having one parent, having that man absent, have a bearing on the outcomes of a pregnancy?
I think that it's most important to have a partner in the whole childbearing and rearing process. When we talked about psychosocial and preparation, I think that women need to be a little bit more in tune with who their partners are when in fact they decide to have their intimate relations with these men. I think that women who are in a stable relationship with a man, when their pregnancies, their outcomes tend to be better because the responsibilities and the stresses of that pregnancy are shared. If in fact a man assumes his role. Now, I have to be careful about making that statement, and the fact that being a product of a single parent home, it's not mandatory to have a man. It's mandatory to have a good parent.
Yes.
And in most instances, that good parent is always the mother. But I think that mother would be even a better mother if, in fact, that responsibility can, in fact, be shared by someone else.
Right. I was just going to add, if I may, that while many of our clients are single parents, they often have a partner, and the nurses are working with that mom and the partner to the extent that the mom wants the partner involved, to really be involved. And we're measuring father involvement, and in fact, our clients show increases in father participation in the family, and that results in a lot of different good outcomes.
I think another good thing, or important thing, is the whole essence of family. That partner it would be nice for it to be a man, but it's good for it to be it could be your mother, your aunt, the extended family. I think that a family or any pregnant woman does better when in fact she has more supportive services available. Women's outcomes are better even during the labor and delivery process when they have midwives involved and doulas involved and concerned nurses. So this whole concept of getting pregnant is not an individual gets pregnant, but it's a family and a group that really is responsible for the outcome of that individual pregnancy.
You know, we are talking about families, and I'm glad you brought that up, because the traditional family, the way it was when many of us were growing up, or the ideal of a mother and father and 2 kids, is just not what the American family is anymore. And so I'm glad you interjected that, because it can be a concerned partner who may not be the biologic father of the pregnancy. Now, one of the things that I haven't brought up a lot, and we talked about it a little bit, but I want to go back to it because we're talking about this continuum, and I have some direct questions there. Dr. Bowers, if a woman is not on contraception, should she be, if a woman is not taking birth control or using birth control, should she be treating herself as if she's about to become pregnant, is my question.
Well, I think that anytime you're having unprotected sex, you may miss your next period, and therefore, if you miss your next period, that means you have an opportunity to become pregnant. And if in fact that's something that is possible, then you should put yourself in the best situation as possible. Meaning that you should eliminate drugs, alcohol, and smoking. You should try to lose weight. You should go to your healthcare provider to make sure that.
One second about the weight. Let me go back just 1 second, because you know that in the African American, the Black community first and the Latino community second, we are the most obese groups around. I was talking about women right then.
Thank you.
Okay. So how much weight in our community does women gain, so that we can give them a clue about how much weight they need to lose before a pregnancy?
Well, I mean, I've never been impressed with women actively losing weight before they get pregnant. Some of our guidelines have changed. For the average size woman who is not labeled to be obese already, we want them to gain somewhere between 25 and 35 pounds during the course of a pregnancy. We've recently changed our standards to those women who are obese, who have BMIs that are 40 and 45. If you start a pregnancy and you're well over 200 pounds, now we've reduced the amount of weight that we want you to gain to be somewhere between 10 and 15 pounds. Sometimes people think that women who are obese are very healthy. Many women who are obese are very unhealthy, and so therefore those the nourishment and the nutrition that a baby would generally get from a average sized woman is not the same as she would get from her obese mother, who probably has more fats as opposed to other more important elements that a factor may need.
So first thing you said is that depending on your size is how much weight you hope that they'll gain during the pregnancy. If you already start out very obese, you don't want anybody to gain the 25 to 35 pounds. What about taking vitamins that have folic acid in it?
I think that the vitamin supplements with folic acid and is very important. One of the things that the incidence is decreasing. Some of the neural tube defects, spina bifida, and some of the meningomyelocele and those things can be reduced by having folic acid as a part of your diet. So folate acid and iron are very important. The iron is important to maintain your good hemoglobin and hematocrit levels, and the folic acid will significantly reduce the incidence of neural tube defects.
Do you go over that kind of thing with your mothers when they're pregnant about taking
Absolutely.
their iron and their prenatal vitamins?
Absolutely. So part of what the nurses are doing is focusing the mom on her nutritional needs during pregnancy and how to eat properly and really, again, but not to be directive, just to say that really giving the information and eliciting the individual's willingness to kind of move forward with a plan to take care of herself better and really for the benefit of her baby.
Do you make individual plans for each?
We do.
Each family that you go into, and they have the components in it? So how does that work?
Well, really each client is a special person, and the nurse is working with something like 25 clients that she visits every other week. And she's working for an hour to an hour and a half with that specific mom and significant other or family member, and really developing a plan for that mom with her goals in mind and her feelings about how she wants to engage in this pregnancy. So nutrition is covered, again, maternal role, thinking about how she's going to make a special place for this baby to come, and then how she's going to plan her life as she moves forward, what birth control she's going to be using, whether she's going to be breastfeeding, because that's a big nutritional issue for both the mom and the baby. And certainly, again, all of these things in the context of a better life for herself and her baby. So using that really dramatic moment of pregnancy when you want the best for that baby that you're carrying, that you're going to birth.
In the few minutes we have left, I wanted to ask you whether or not once a woman has had a low birth weight baby or some other problem, are they likely to have the same thing again?
Yes, they repeat. It repeats itself at about the same gestation. And I was just wondering, I wanted to throw in that perhaps the education and preparation should be handled early on, like the teenage years, like in high school, or more education should be given along the lines of either prevention or preparing for this planning. They plan for their prom night and their wedding more than they plan for their pregnancy.
Wedding? Okay.
Another thing too, Dr. Sweeney, is the fact that I have had the experience of gay parents having a family. I think it's a wonderful, wonderful idea seeing them have it, and it's a very nice occasion for
Love
them.
doesn't depend on what gender one is.
Yes, and it's just beautiful, and I just marvel at what I do with these small babies. And
we marvel at what you do with small babies. Yes, Dr. Bauer.
I think that I don't think the opportunity should be lost to promote the concept of breastfeeding. I think that breastfeeding in our communities has not been received in a manner in which it should be, and I think that there are some significant health advantages to breastfeeding. And we just had a lecture just this week. One of the things that Dr. Valencia alluded to before was the infection. One of the more damaging infections. In fact, I lost one of my own children to NEC, a necrotizing enterocolitis, which is an infection process in and of itself, and just the breast milk in and of itself may be protective and help, and so therefore, if when in fact you're planning on having a baby, or whether you get pregnant and you haven't planned on it, I think you should consider the possibilities of at least trying breastfeeding. If it's something that you try and you don't like it, then that's fine. But I think that to be a good mother, you need to, good mothers do for their babies in spite of themselves. And I think that breastfeeding, I think, is something that in fact we should be trying to promote more of.
In the couple of minutes that we have left, I'd like you to give the audience a takeaway message. So let's start with you, Lisa.
Great. Well, to give your baby and yourself the best start with your pregnancy, Nurse Family Partnership is a terrific program. It sends a nurse to your home to work with you on all the kinds of challenges that you might be facing during the course of your pregnancy, and that nurse stays with you for 2 years, coming to your home and helping you become the parent that you want to be. and really helping you to connect to others in your community and other services that you might need, so that you give yourself and your baby the best opportunity to move forward. So who better than a nurse to be leading you in that new moment that you have to create a future for your new family.
Is it right to say it's free of charge?
It is free of charge, and it is accessible through calling 311 and asking for Nurse-Family Partnership. We're in all 5 boroughs in a lot of the neighborhoods of Brooklyn. So we hope that we can offer this program now and into the future. We have 2,400 families in New York City right now that we're serving, and we aim to grow our program.
Terrific.
Thank you, Monica.
Dr. Valencia?
Well, the consequences of a pregnancy that goes awry is a sad moment. But I want to assure the community of Brooklyn that we are ready to meet that challenge, as we are doing every day. We're there for them. We have cutting-edge technology, and between Dr. Bowers and I, we could do the work.
Dr. Bowers?
I mean, I think that I can only compliment what Dr. Valencia says. I think that the care that you're going to get on Clarkson Avenue at Kings County Hospital, which is where I'm responsible for with our leadership and our new facility, with Dr. Valencia at Downstate, we've been providing excellent health care to this community for well over 100 years. If we take the 2 hospitals together, we've been providing services for over 200 years on a collective. Nobody cares about Brooklyn more than the doctors on Clarkson Avenue. And I think that, we're you. In other words, when you come to the Clarkson Avenue, the doctors are going to be taking care of you, are going to look just like you. We all come from roots just like you. And we're going to give you not only our intellect and our science, but we're going to give you our hearts. And I think that that's the most important thing that we can offer you, the best science, but more importantly, the best hearts that are available in Brooklyn. And I think you can get that on Clarkson Avenue.
The head, the heart, and the hands.
You got it. That should be our new slogan.
On Clarkson Avenue. We're going to have to leave it there. I thank all of you for being here, and we're going to see some better outcomes of pregnancies and fewer low birth weight babies, but I don't think you'll have to worry about being closed in the NICU anytime soon. Yeah. Thank you all very much for being here.
Thank you.
Thank you.
Thank you.
That's all for this month. If you want to watch past episodes of the show, go to brickartsmedia.org/BIT and then click on Healthbeat Brooklyn. And you can follow us on Facebook or Twitter on BK Independent Television. Right now, information about the programs and hospitals we've just seen is about to appear on your screen. Thanks for watching, and stay healthy.
Watch this and other Brooklyn Independent Television episodes online at brickartsmedia.org/BIT.